I came from the wrong direction. All right, so let's see if my slides are on. Perfect. All right. My name is Dr. Odinachi Oguh. Everybody calls me Dr. O. I am a movement disorder neurologist here at the Cleveland Clinic in Las Vegas, Nevada. I run and direct the comprehensive ataxia clinic here. So I see a vast majority of patients who have ataxia and different types of ataxia. So I get to see people who have traveled far and wide, who are seeking diagnoses. So I'm going to start with a case of a patient who came to me for a diagnosis of ataxia. But before that, I have nothing to disclose in terms of this lecture. So let's get started. So when we talk about ataxia, many of us will understand the journey that it takes to get diagnosed. So I have here a 71-year-old female. She used to be a previous Las Vegas dancer, so you do need a lot of coordination for that. She danced for some of the greatest shows on the Strip. She retired and was an avid hiker, but began to notice changes in her gait over the last 1 to 2 years. She particularly had no family history, and her clinical symptoms from where she, how her gait had changed, where she was just feeling that her gait was, there was some incoordination of her gait, there was some sort of a slurring of speech going on, so things she couldn't articulate or sing like she used to. And she just had difficulties with getting her activities of daily living done. So simple things like brushing her hair, combing her, brushing her teeth, things that require fine finger movements were just difficult to do. So by the time she came to me, she had gone through 3 neurologists, and I think this is a familiar history with a lot of people. They go see their local neurologist, and the neurologist said, oh, maybe this is old age. Or, maybe as you're aging, things are just getting slower. And then she didn't feel that because she was quite active as a grandma. So she sought another neurologist, and the neurologist indeed did do some testing. And in cases like this where there's no family history of anything, most of the testing that we do truly points to looking for symptomatic causes of ataxia, whether it's looking at medication, looking at toxins or heavy metal screening, or looking at paraneoplastic disorders. So it's certainly when we navigate the course of diagnosis, we think about the acuity of presentation, how long you've been having symptoms for. For many of us that do have a genetic history or familial history of ataxia, it is certainly a very slow and long progressive course of symptoms. But there are some people that don't always have that familiarity or family history of ataxia. So oftentimes what we tend to see is that patients may recognize symptoms within 2 years, and usually we call that much more of a subacute presentation. And so when we talk about subacute presentation, then we start thinking about other symptomatic causes of ataxia. And so understanding family history can be important, but it's not always present in every patient who has ataxia. And I always think about what are the diagnostics that are often present in patients who have ataxia. So by the time they go see their neurologist, they, have done certain labs, including paraneoplastic workup. They have looked at medications to see if any of that is pertinent to their clinical diagnoses, and sometimes you may have, have done an MRI to determine if there's any structural abnormalities that are involved in ataxia, because we do know there could be other structural causes of ataxia. Mostly those do present much more acutely in terms of the presentation, such as a stroke or space-occupying lesion like a tumor, although sometimes, that history can be sometimes confusing if you're not looking out for those types of symptoms. So going back to our patient, she decided to seek out expertise in her symptoms because, again, she wasn't really arriving at an answer. So I think this plays to some of the difficulties we have with ataxia care, right? Because oftentimes what we tend to see is that the knowledge, even among movement disorder neurologists, is not uniform, and that's why we have the SHARE initiative of the National Ataxia Foundation to provide clinical education to fellows and doctors about ataxia, but it's not always uniform among providers. And access to care, which is an ever-growing question in our healthcare environment, can be difficult to sort of seek that expertise in care. And so, again, the goal is if we improve education among general neurologists and expert movement disorder physicians, that we can, again, improve diagnoses. But this is not always the case, but these are certainly the tools that we need to improve that expertise in diagnosis. So for my patient, when I examined her, these were some of the things that I certainly see or saw in her case. Certainly she did have motor symptoms. So, and she had some complaints of vestibular symptoms also. So things like vertigo, and I know a lot of patients will call this dizziness, but again, pinpointing what that dizziness is, because certainly there are different types of dizziness. People will report whether this is a vertigo type presentation where you feel a disequilibrium or the spinning of your world or yourself can be something that is very indeed present in a lot of patients with ataxia. And also, we can also have other non-cerebellar presentations, such as cognitive or neuropsychiatric symptoms. So I always put the bank of clinical symptoms of ataxia into sort of three big categories. Motor symptoms, which could be things like gait, incoordination, limb incoordination, balance issues, falls, which can be a problem, clumsy hands and feet, and slurred speech. We also have some patients who have a spasticity with their ataxia. And when we talk about spasticity, we talk about just that stiffness of the muscles, and makes it really difficult for mobile movement or functional movement in ataxia. And then we do have some swallowing difficulties, which can also be present in ataxia patients. We also can have vestibular symptoms as well. So when we think about vestibular symptoms, we're talking about vertigo, which can be the most common presentation. But it can also be a disequilibrium, which is something that can happen very frequently, which we often forget the influence of our vestibular system in just maintaining posture. So things like turning can be difficult because of your vestibular influences. So turning from one position to another can be very difficult because of that disequilibrium. And so you hold difficulties with just posture and balance, which can be present. And then we have the common vertigo, which can also be very present in patients with vestibular disturbances. Even though we often don't recognize the impact of cerebellar function on our executive function, our mood, those things can also happen in patients with cerebellar dysfunction. So again, in my patient, she had some of the symptoms present, and diagnosing this just based on clinical presentation is important. I think as a neurologist, the thing that we are clinicians as far. So examining that patient, detailing the symptoms can be very important in that diagnosis. So the next step is sort of, how do we diagnose this patient? She doesn't have a family history. She had clear symptoms originating from her cerebellum. And I'm going to put this next slide, not because I want you to sort of memorize it, but because sometimes it can be such a confusing path in terms of diagnosis, and how do we really begin to think about diagnosis. But I think streamlining things is really important. The first step I always do with all my patients is getting an MRI to determine what kind of ataxia. Because again, we do know that at the time you present with symptoms with ataxia, there is a certain amount, especially people who do have genetic or ataxias, we do know there's a certain amount of cerebellar volume loss that happens decades before we begin to even present with clinical symptoms. So that cerebellar volume loss can be determined and seen on an MRI, MRI volumetric analysis. There are many ways to determine cerebellar volume loss. And I always tell my patients, by the time you present with symptoms, there is a certain amount of cerebellar volume loss that is present on imaging to determine. And so this is often goes with a lot of our patients who have genetic or hereditary types of ataxia. I say again, there is usually volume loss on MRI. And so we can always determine that. And so what we do look for is cerebellar volume loss. I also look at the midbrain to kind of see if there's any loss of volume on the MRI. So the next step is, do we do genetics? So as I said, by the time my patient came to me, again, she's had 2 years of symptoms. So she had already had a lot of the symptomatic walk-up. But based on her constellation of clinical symptoms, there was certainly worry that she had much more of a genetic presentation because she also had cerebellar volume loss on her MRI. So we ended up thinking about and discussing genetic testing. So genetic testing and that discussion can be very intimidating for a lot of patients. How do we navigate testing? Do we want to get tested? Do we want to find diagnoses? I can tell you, there was a young, I think he was 26 when he came to see me. And he didn't really want to know what he had, and he still doesn't want to know what he had. So there is that consent that you have to get from the patient in terms of that genetics. And a lot of people want to get genetic testing because, again, they want to know what they have. And secondly, they want to know what's the risk in their family as well. So we often have to go through that genetic testing. Sometimes we don't have that access to genetic counselors. Thankfully, with telehealth and telemedicine, we can certainly refer to genetic counselors that are outside of our referring field or area. But again, I would say that it's not very present in all locations to have a genetic testing or genetic counselor present. But again, as movement neurologist that specializes in ataxia care. I'm very comfortable in having that conversation and then getting the consent of the patient to have genetic testing, because it can open a lot of doors to diagnosis of that patient. So we did do genetic testing in this patient. We tested for the more common ataxia genes, and then we did something called whole exome sequencing. So a lot of the patients who may not have the common ataxia genes really check for the more common ataxia mutations. But we do know in certain patients who have no family history, that what we call that strike of lightning effect, where you become the first proband in your family to have a diagnosis of ataxia. They may not have the typical ataxia mutation. And so what whole genome, whole exome sequencing does is to sort of look for those missense mutations that might not show up on a regular ataxia panel. So those are the set of testing that we look for. But if, say, a patient had come in with a family history of ataxia, they already knew what type of ataxia runs in their family, then we could just do a targeted testing. So we could just check for specific genes to determine that diagnosis. Again, that's an often easier pathway in terms of testing for ataxia. But again, I think that the field of ataxia is expanding because we're having all these patients who may not have family history of ataxia showing up with clinical symptoms of ataxia, especially as they're getting older. And then we have to seek out what type of ataxia they have. So again, understanding diagnosis really starts with the patient. Understanding, number one, if there's presence or absence of family history. Number two, the acuity of their presentation, if this is short or long. And then focusing that diagnostic testing and streamlining that test could be important. Now, I would say that I am often, most of the time, 70% successful in helping diagnosis, but there are patients that still run into that, what we call idiopathic ataxias, where we have done everything and there's still not a diagnosis. And we'll talk about it a little later. But again, as I said, the nuances of diagnosis is, again, understanding family history, if it's present or not, acuity of symptoms, importance of history and examination, and also increasing our diagnostic quorum of the extent of genetic testing, which continues to improve every year that I practice. And always having that long-term relationship with your neurologist to help navigate in terms of new testing, new diagnoses, things like that. So we ended up diagnosing the patient with SCA8. She had no family history, as I said. She was the first person in her family that had this diagnosis. It was very important for her to have this diagnosis, given that she has children of her own and grandchildren, and how that will affect. So the next step after diagnosis becomes I would say, is a diagnostic visit, which is a more extended visit and diagnosis. But let's kind of clarify some of the classifications of what ataxia is. So I think I put it in sort of three big categories because we often get so many terms. I remember last week I was on the Birds of a Feather session, and one of the questions a patient asked was, I hear so many terms of ataxia. Some call it idiopathic, some call it genetic, some call it hereditary. And so how do you explain this classification? So I typically put patients in three big categories because just to make things simple, we have too many complicated terms in our lives. So So the big one is always our genetic ataxia. So in genetic ataxias, there are different types of genetics in ataxia. So when we think about the genetics in ataxia, we think about autosomal dominant ataxias. So typically, it means there is one parent with ataxia, and then that is transmitted to the child at a 50% chance. So each child has a 50% chance of presentation. So those are most of our dominant mutation. I think we have up to 48, if I was counting last, I counted, of different types of dominant ataxias. And then you have the recessive ataxias. So recessive ataxias, again, the most common one is the Friedreich's ataxia, meaning your parents don't have don't have genetic presentation, but they are carriers of a specific gene, both parents. So you inherit both genes from the parent, and so the child then has a risk of ataxia at 25% per child. And so someone in the Birds of a Feather asked, how come every one of my siblings has ataxia, even though it's a 50% chance? And I was like, well, unfortunately, we only know the simplified genetics in ataxia. We don't understand every aspect of why in a family there is that higher chance. But again, if we look at the risk per child, it's a 50% chance per risk in a dominant mutation. So it's really literally a flip of a coin in genes. So in recessive ataxias, and I think recessive ataxias are often missed, and that's mostly because sometimes they can skip generations. And so, as I said, it's a 25% per child to have a recessive ataxia. I had a woman, I believe she was in her 70s, came in, she was already chair-bound, didn't have a diagnosis of ataxia, and literally tested her because her family history did determine there were, again, several of her siblings with similar presentation, and found out that she had Friedreich's ataxia. Again, Friedreich's ataxia is the most common form of a recessive ataxia, and the world of recessive ataxias are expanding as well. So even though Friedreich's ataxia is the most common one, we have the YE1 type of ataxia. We have so many other types of recessive ataxias. Again, parents don't have clinical symptoms, they carry gene, you inherit both genes, and it's a 25% chance. And then you have the X-linked ataxias, where it is really transmitted from the mother to the child, to the son. So again, because the sons only have one X chromosome, and so in X-linked ataxia, its mom transfers that to the son. Now the daughters become carriers, and there's always a chance if they have a son, they can get that mutation. Then we have mitochondrial ataxias, which are a vast growing field of ataxias, and I think those are really more X-linked because we inherit most of our mitochondria from our mothers, and so again, this is a different type of genetic ataxia. And then we go into the idiopathic or sporadic type of ataxia. So idiopathic or sporadic means we have checked for everything and it's come back negative. Now, I always go through the rule of 1/3 in idiopathic ataxias, meaning 1/3 of patients with idiopathic ataxias, we have some sort of neurodegenerative presentation of ataxia, and that's typically sort of the MSACs. Now we have skin biopsies to help with those patients who are still undiagnosed to see if they have what we call alpha-synuclein seeding, because alpha-synuclein is the protein that we do find in MSAC. So that can certainly be helpful. We have dopamine scans to help in those patients. And then 1/3 of patients may still have a genetic mutation that we just haven't found. And sometimes it's worthwhile repeating genetic testing, maybe 5 or a few years after, just to see if there is a reoccurrence or something that we had missed on the first testing. Because again, it continues to show us that in patients who do have ataxia, there's often there can be new genes found in those patients. And in the idiopathic ataxias, a lot of patients also do have something called canvas, which is another type of ataxia that we often don't test in the routine ataxia testing. And then in 1/3 of patients, there still could be a possibility of symptomatic ataxia, such as paraneoplastic disorders. One of the things I always advocate for in symptomatic ataxia is, if we do a spinal tap, you want to make sure, if we do paraneoplastic testing, we do want to make sure we're getting spinal tap and blood as well, because that will help us in eluding any type of paraneoplastic ataxia. So again, paraneoplastic ataxia or symptomatic ataxias are the last kind of ataxias. Again, we do have trauma, stroke, paraneoplastic, infections are all what we call symptomatic. So in symptomatic ataxias, is typically something has triggered that ataxia to cause symptoms of ataxia. So those are my big classifications of ataxia. So now that we got that all straightened out, so once diagnosis is given, what's next? I always advocate for educating oneself of ataxia. And with the National Ataxia Foundation, there's so many avenues in terms of education. Informing oneself is very important when we have these diagnoses. We want to vet sources of information. I always refer my patients to the National Ataxia Foundation. They have a wealth of information and sources that are helpful for you. Do you often receive health information from a healthcare provider? What is given during that second visit, which is that diagnosis visit, which you really spend time with the patient in discussing their diagnosis. So educating oneself is so important when we think about that diagnosis because there's so many wrong information on the internet. And so directing the patient to the right sources of information is so important. Planning ahead, again, a lot of my younger patients who come in terms of their diagnosis with ataxia, they're asking about future, they're asking about job, they're asking about things like long-term disability, what should I be doing, what are my family members, should I get the genetic testing to my family members? I can tell you what my patient and what we discussed. She was already a grandmom. She had 3 sons and a daughter already. And so her question to me is, do I tell my family about my diagnosis? How do I navigate that discussion with my adult children? And I always tell patients, it's certainly your right, to have those conversations with your children and tell them. And so if you're open, you should tell them about diagnosis. You could also talk about testing. Again, as the fact that they're adults, they have the right to make that decision whether they want to get tested or not, to see if they have genetics or positive genetics for certain types of ataxia. So since now mom has SCA8, they can be very much targeted in their diagnosis to see if they do have the gene. And so I always encourage patients to just have conversations with their family, have conversations with their adult children about testing if that's something they want to pursue. Now, in younger patients who may not have had the testing done or for younger patients who have had tested and still are thinking about raising a family, there's a whole wealth of diagnosis and discussion, right? Because number one, should I tell my job? That's the first thing that they always ask. I tend to really tell them that, unless if your job is asking questions, it's really your right to decide if you want to tell them or not. Because sometimes, in our workforce, there can be discrimination, and how do you navigate that? Discrimination when you do have a job, things like that. I have a young man who's an electrician with Ataxia, and he is certainly trying to navigate some of his job responsibilities. And how do you do that? How do you modify what you have been able to do all your life, and now you can't? And we do know some of that long-term disability comes into play because most of us don't have that before we get diagnosed. And so how do we navigate that? Which is a very difficult conversation for a lot of young people who do have ataxia. So we talk about fertility with the advances in IVF. We can certainly navigate that process and things like that. So there's a very long conversation about planning ahead in that second visit once you get diagnosis. Understanding oneself. So we do know that even with the National Ataxia Centers of Excellence, there's still a few and far in between in terms of providing that access to care. And so you may have to seek care and ataxia expertise outside of the location if there's none for you. And sometimes it could be a one visit at a center of excellence, and then seeking out a neurologist locally to help manage symptoms, and going maybe annually to see an expert might be the way to go. I think this is something that we are still working on as a healthcare system in terms of just the access to care. But again, there are so much resources in terms of the National Ataxia Foundation and bridging that information barrier. And then giving yourself in terms of research or not research, and I know there are so many ways to be involved in research, whether observational research that you can do through the internet. So there are so many ways that could be involved in research. And as a clinician, we learn more from our patients. I mean, our patients embody the wealth of information that we need to understand as clinicians. So support, I always say, you want to be involved in several support groups, and it can be very anxiety-provoking for certain patients who newly get diagnosed. And so sometimes a gentle introduction to a support group might be helpful, but I just know community is so important in ataxia, and that community helps you through this journey that we all intake with a diagnosis of ataxia. So maintaining those connections are so crucial, and I think I heard it last week on our virtual conference of how that is so important in fostering the support, fostering community through this journey that is ataxia. So one of the things that I often dislike hearing is that after you get a diagnosis and someone says to you, well, there's nothing I can do. Well, I dislike that because there's so much we can do with ataxia. All ataxias are treatable, and certainly we don't have a cure for a lot of the ataxias, but we do know that there is so much we can do for ataxia patients. We do know certainly there are a few ataxias that have specific drug treatments, like Friedreich's ataxia, but the knowledge in ataxia continues to increase, and I think in the next decade we will certainly have treatments for other types of ataxia. But there is so much we can do through symptomatic therapies for ataxia symptoms, through adjunctive therapies, whether physical therapy, occupational speech therapy, and what you also do at home in terms of exercise, your diet, are so much important in this, in the lifestyle changes that have to support ataxia. So that is so important. And I do believe in the multidisciplinary approach to ataxia and that wraparound care around the patient in terms of focusing on symptomatic therapies, adjunctive therapies, psychosocial or psychological support for the patient. So again, your multidisciplinary team should look like this, but it often doesn't. And I always tell patients, again, in this journey that is ataxia, you're going to meet a lot of people along the way. And it's often helpful that we are able to collect those names along the way that would be helpful in our journey of ataxia. Because there are sometimes a patient will come to me and say, you know what, I found this wonderful PT person close to my home, and he really helps me with different aspects of my ataxia care. So I was like, that's great. We should work with him more, things like that. So in this journey in ataxia, I say you have to sort of build your tribe in terms of who will help us through this journey that is ataxia. So what's my diagnosis, my newly diagnosed checklist? I think number one is empowering yourself is key. We do want to make sure that we're empowering ourselves with information, we're empowering ourselves with developing that long-term relationships with our neurologist. We are making sure we are documenting our journey through ataxia. You see your clinician maybe once every 6 months, once a year, your expert neurologist. You want to make sure you're documenting your symptoms so you can have a clear conversation. I love when a patient brings a checklist to their visit because I go through that checklist. It helps my visit. I said, let's go through your checklist before I go through my questions, because it really helps us focus what the needs of that patient is during that visit. And so this is so important. And knowing that there are symptomatic therapies that can help you, there are adjunctive therapies like rehab, PT, OT that can be helpful to support your symptoms, as well as psychological support certainly helps symptoms of ataxia. So again, discussing with your neurologist, endearing that long-term relationship is so important in terms of once we get diagnosed, how do we establish that tribe and community in terms of ataxia? It's so important. I believe this is my last slide, and the last few minutes I will take some questions. Thank you.
Any of that crossed over with ataxia? She does have ataxia too. Are you able to speak in the mic? Oh, I'm sorry.
So she has clinical symptoms of ataxia and
POTS and CRPS, and she has nodules on her thyroid. Mm-hmm. And she goes blind every day.
So again, you can have other comorbid symptoms associated with ataxia. It certainly depends on the type of ataxia that she has been diagnosed with. But like the autoimmune ataxias or the paraneoplastic ataxias do have a lot of other comorbid symptoms of ataxia. So understanding what type of ataxia you do have would be helpful instead of putting all those symptoms together. But I do know with autoimmune ataxias, which are your paraneoplastic ataxias, you can certainly have a constellation of other non-cerebellar ataxia symptoms. Even in the genetic ataxias, you can have certain types of ataxias like SCA10 that you have seizures with. So again, there could be other non-cerebellar ataxias associated symptoms with ataxia.
Her doctor had just said, yeah, you have ataxia, but don't worry about it, you're fine. And did nothing else. So we're learning from searching online mostly.
Yeah. So we do need an appropriate diagnosis. I think that will be the key to sort of understand exactly what the constellation of the whole clinical symptoms are.
Okay.
Yeah,
Thank you.
you're welcome.
Any questions?
I'll take this one first.
You want me to go?
You
All
wanna
right,
go?
doctor, to your left here, we have Linda.
Hi, I was wondering, when you were talking about the 3 different types or the 3 different buckets, idiopathic, sporadic, genetic ataxia, and then symptomatic ataxia, I was wondering if you, if symptomatic ataxia, say one caused by an infection, could become hereditary. Is it like once you get the ataxia, then there's a chance of it being passed down, or do you really need to be diagnosed with one of the genetic or in order for that to be
Passed down. Correct. Yes, you do have to be diagnosed with a genetic ataxia to have it passed down. So in symptomatic ataxias, and one of them I forgot to mention is alcoholism too, can result in symptomatic ataxia. The damage is already done, so there's no passing down to the next generation.
Thank you. We have a friend who has the JC virus, if you're familiar with that, and I wondered if delphampridine, which helps with MS-type symptoms, could help a JC virus patient.
So number one, is it something that is acute that she had, or is this a chronic? And JC virus is something that is difficult to completely clear. Sometimes there are immune therapies because it's not the actual virus that could be the factor, is the ongoing immune inflammatory reaction that happens after the initial infection. So yes, there might be some immune modulating therapy that can be helpful. That is certainly after the initial virus has been treated.
Okay, doctor, to your left, we have Pamela.
Good morning, and thank you for being here to present to us. I would like to ask a question in regards to preparing for a visit with a neurologist. And in your perspective, I would love to know how valuable you think it is for a first-timer, for initially diagnosed with it, to have a patient advocate with them at this appointment.
I think it's so important to have a patient advocate. Number one, let's start from the beginning. How do we prepare for a visit? I always say, have your questions ready. Because oftentimes you walk into the appointment and you're like, oh my God, I can't even remember what I want to talk about. So I think having your questions ready, even on your phone, on your notes, just to be prepared for the appointment would be so important. And so there, as I said in my lecture, there's so many questions that you could ask, diagnosis, family, genetic testing for my grandchildren, things like that. Symptoms that are bothering me, how can I tackle that? So having just a checklist on that day is important. And sometimes, you're seeing this doctor for a visit, I don't know how long they would have, so really having a more focused direction for your questions would be so important. And number two, advocates are so welcomed. We want an advocate who would remind us, okay, this is something that you really wanted to ask, or this is something I want to ask during this visit. So I think having an advocate with you is so important, whether that's a friend or family member who is there with you during that discussion about diagnosis is so important.
Hi, I'm a third-generation female with symptoms of disequilibrium and swallowing problems. My mom saw the neurologist at Arizona Mayo Clinic, and Barrows, I'm sorry, and had one genetic test that came back negative, and the doctor's response was, that's all we need to do. Kind of sounded like you don't have a problem, which we obviously do. What's the next step, I guess, for something that is genetic? Obviously, do we keep doing different testing? And is anyone gathering the DNA for people that don't meet a specific diagnosis yet of one of the identified types in order to try to identify more? How does that work?
So that's a very interesting question. So yes, as I said, most people just stop at the common genetic ataxia gene. So there is a set of them that tends to happen. So the first question, what do I do next? More genetic testing. So if it indeed has had 3 generations of females with ataxia, then we have to do more genetic testing. And this could be a whole genome testing or a whole exome sequencing to kind of determine what's that next step. Now, if that comes back negative, then the only one that we haven't checked that is not part of that whole spectrum of whole gene testing or whole sequence testing is the Canvas, which is a different test because, again, with Canvas, you could have, other vestibular symptoms. But I always say that there is a need for sometimes a genetic counselor to help sometimes maybe streamline my knowledge. So sometimes after I do a whole genome or a whole sequencing and I know that they have something, what else am I missing? I might send them to a genetic counselor to help tailor that whole information into something. And so sometimes that can be helpful as well. So there's many things else you can do in that presentation. And then I talked about idiopathic ataxias. What are the next things do we have? We do have, is there MSA, other things that you kind of have to think about in that presentation of idiopathic ataxias. But again, I always start with checking the most common ataxia genes. I might reflex to whole genome or whole sequencing. And then if that's negative, then, do I get in a genetic counselor? I probably will get a genetic counselor before all of that, just to help me tailor things. And then you have Canvas. So there's so many ways you can go in terms of diagnosis and genetic, especially if it's truly affected. And then you kind of have to think about mitochondria. As I said, there's so many other types of genetic testing that are not in that common ataxia panel that we all check for. And then the second question that you had asked in terms of is there other things that can be done? As I said, yes, there is. There are other things that you can do in terms of that diagnosis.
Okay, Doctor, on your left, we have the next question from Lauren.
So I was wondering, when you were talking about how people start showing symptoms, clinical symptoms, there is a noticeable loss in cerebellar mass. I was wondering why the symptoms don't start showing sooner if that's noticeable.
Well, the brain has a beautiful capacity to compensate for symptoms. So there is always a threshold where the brain says, you know what, I can't do this anymore, and begins to present with symptoms. So that threshold could be different for everybody, but there are certain things that might determine that threshold. Number one, the amount of gene burden you have, and number two, the penetrance of that gene burden. So yes, the brain has a beautiful capacity to compensate for symptoms for as long as possible, but there's a threshold that we all reach, and I'm not sure it's the same for everybody, that then results in that presentation of symptoms.
Good morning.
Morning.
Hi, my question is, what is the reason because the patient with ataxia always has the cold feet?
Repeat that question again.
The patient with ataxia always has the cold feet and hands.
Good feet and hands or comes?
Yes, the feet and hands always is cold.
Cold. That is a good question, and I'm not sure if it's just related to ataxia or other non-ataxia symptoms with how we respond to sensation in our body. We do know that neuropathy is very common in ataxia patients, and your temperature regulators are some of the finest nerves in our skin, and sometimes with neuropathy, you can present with cold hands and feet as some of the early symptoms in sensation loss, and sometimes that progresses to other sensory loss. I do know in Friedreich's ataxia, for example, vibration and proprioception loss are lost early on in Friedreich's ataxia. So yes, you can have temperature changes because of sensory loss in ataxia patient that can result in cold hands and feet.
Okay, thank you.
You're welcome.
All right, next up we have Sally.
I'd like to know, in my experience, those that have experienced trauma, their symptoms, their ataxia symptoms are more pronounced. In my personal case, just when I'm ill, I find it, my symptoms are much worse. What about having an operation? How would this affect, or could it affect your the severity of your symptoms?
So trauma in ataxia, I do know that trauma causes much more of what we call an outflow syndrome. So because when trauma hits, it doesn't sort of just hit a little pat, which is very different in sort of our hereditary and chronic ataxias where there's a slow buildup of those symptoms over a long period of time. Trauma is an explosion of symptoms, so we call it an outflow syndrome. And so that's why the presentation of trauma-induced ataxia tend to be so outflow, so intense, and that is because trauma just involves, when trauma happens in ataxia, it involves the whole pathways of ataxia. I always tell patients, like, the cerebellum is not an island, so when we hit with trauma, it causes sort of an outflow syndrome of all the possible cerebellar symptoms in trauma. So trauma patients with cerebellar ataxia usually have something called a cerebellar outflow syndrome because of the intensity of symptoms, which can be such a more pronounced presentation. Now, when we have surgeries or we have illnesses, I think this is common for a lot of neurological diseases. There's usually stress, unmasking that can be placed on our brains in general, and that can result in a worsening of symptoms, and the ability to recover is longer as well. So again, we've just gone through a pandemic, had a lot of patients with COVID, or even now we're going through a flu. Just having those symptoms can unmask neurological symptoms even more and make it more pronounced during the time of the illness. And our recovery from illness takes longer as well. So those are things that we see that's not just unique to cerebellar ataxia, but unique to a lot of neurological diseases as well.
I was wondering if a mother with Friedreich's or diagnosed with Friedreich's could have an SCA daughter with SCA6. I was genetically tested. I'm the only one that I know of that's been genetically tested, but I'm the 4th generation.
So what I understand, mom had Friedreich's and then you have a different. So again, that could be what we call a strike of lightning mutation, meaning you are now the first person with that type of mutation in your family, not necessarily inherited from your mom or family member, but again, a strike of lightning, meaning that you have that new mutation present. And a lot of those mutations tend to be missense mutations that cause that once in a strike mutation. Like my patient, she didn't have specifically any family history, but she then developed a dominant mutation with a different type of mutation than what is typical for even SCA8. And that most of them tend to be missense mutation.
And also, I have a son and a daughter, and I know it's a 50% chance of either one of them could be getting it. They don't want to be tested, but could the female only get it? Because it's only been females so far in the last.
So if you do have a dominant mutation, then it's a 50% chance per child. It's not specific female or male. Only if it's an X-linked mutation, then it tends to be more female. More male. But most ataxias tend to be 50% chance per child, so it doesn't discriminate.
Okay, doctor in the back, we have Keely.
Okay.
Hi, thank you for being here today. I'd love to hear more from you about the gene burden concept, how it's measured or tested, and what strategies, depending on the level of gene burden a patient presents with, what strategies of treatment you may recommend.
So gene burden is very common. I think the most simplistic concept is some of our what we call a trinucleotide repeat mutation, which is sort of common, let's say SCA1 or 2, which are the most common trinucleotide repeat mutations. So what tends to happen is that the trinucleotide repeat, the bigger the gene amount of repeats that you have attached to your gene, the earlier the presentation of symptoms. Now, I know there probably could be some movement disorder neurologists who would argue with me and say, that doesn't explain anything. Yes, you're completely right. It doesn't explain the whole gene burden, but as far as we understand, the more the trinucleotide repeat, the more earlier the presentation, as well as the penetrance of the gene as well, can also determine the intensity of symptoms as well. So those things are what helps with gene burden. Now, when for most gene inheritance, say from father to daughter, what tends to happen, there could be a mitotic instability in the embryonic stage. So what happens is that there's a higher amount of gene passed on from father to daughter if that happens. Now, there's only one gene that's maternal influence. I think that's SCA8, where if you inherit it from your mother, you have an increased possibility of having a higher gene burden to the children who inherit it. But yes, those are some of the concepts of gene burden that can be present in some of the genetic mutations.
Okay, we have time for.
I think that's all.
Okay, we have time for one more.
Then did you want to do your question or no?
Thank you. I would like to know if you have any data, information about a relationship between Charcot-Marie tooth and ataxia.
I don't know if specifically we do have genetics in terms of relationship, but now Charcot-Marie tooth can cause what we call a more sensory ataxia. So in Charcot-Marie tooth, you do have a denervation of your nerves. And when you do have a denervation of your nerve, you truly will have a sensory ataxia. So there are clinical presentations that could happen, i.e. you walk more wide-based, and that is because your sensation is gone. We fail to understand the sensation, how sensation controls coordination and balance in ataxia. So that in itself can be something that can happen in that sensory ataxia that can happen. I think there's a family in the back that has had their hand up. Maybe I take that last question and then we'll be done.
Hi, Dr. O. My name is Sharon Bird, and my family, several family members have SCA3. I heard you mention that there is a specific drug for Friedreich's. My question is there a specific medicine that's geared toward SCA3?
So not yet, but we have a lot of research currently looking at SCA3. I do know that the drug triarulazole, which is the one that has been tested, is currently being tested in SCA3. It hasn't gotten FDA approval, but we're putting our hope that this new fast path approval process would be helpful to get it approved. And I do know either Biogen or some other companies also looking at genetic treatments in SCA3. So I'm hopeful that in the next decade we will have specific gene and medications targeted to SCA3, but right now, no FDA-approved medication. All right. Thank you so much.
Yeah.
All right. All right. First session's in the books. That was outstanding. And thank you for all the great questions, Dr. Oguh. That's a great way to start this session.
Absolutely.
And now it's time for people to get on the move a little bit, Dana.
Yeah, we're going to let you get up, move around. So we do have some birds of a feather sessions that are happening from 10 to 12. So check the book on page 4 to see if you're attending one of those sessions. If you're not attending one of these sessions, and for our virtual audience, at 10:30 you can come back to this room for adaptive Tai Chi, and then in this room at 11 will be rhythmic rehabilitation. And then we'll break for lunch from 12 to 1:30, and so we'll see everyone back in this room at 1:30.
There you go. And for folks who are trying to find their location where their Birds of a Feather session is, there will be folks out in the hallway being able to guide you to where your session is. So, hey, opening bid on the ties at $800. So, Jim, I'm telling you, now you know what you got to beat. All right, have a great session. We'll see some of you back here at 10:30, and especially the folks online with us. Have a great morning.
Have a great morning.